Hi team, that's Walid Tawfiq again. We have a scenario today about a 65 years old man who had presented to you by severe right knee pain in the last 2 years. What do you see and how you are going to manage this case? So this is a clinical photograph and a couple of radiographs for the knee for this gentleman that show severe varus osteoarthritis of the knee. The the radiograph showing severe defect of the medial tibial plateau with tri-compartmental osteoarthritis predominantly on the medial side. There is subluxation of the tibiofemoral joint. So this is an example of severe knee osteoarthritis. My other differential diagnosis of varus malalignment of the knee. In these cases, degenerative. Other causes can be traumatic, metabolic, or iatrogenic of previous osteotomy. So I need to take a detailed history from the patient as regards the present complaint, ensuring the pain is originating from the knee. History of fit flags suggesting serious pathology. I will do an Oxford knee score, what treatment received, and what the outcome of that. I will ask about past knee history in terms of trauma, surgery, and treatment. Other joint history, ipsilateral hip, and past medical history, how fit is the patient for surgical intervention, and the presence of major comorbidities. I will examine him generally for the BMI. Locally, I'm looking for the standing alignment, skin and scars, and soft tissue condition. Ask the patient to walk, and I will examine his extensive mechanism, patellar tracking, feel for point of tenderness and diffusion, his range of movement to check for effects of flexion deformity, stability of the knee for cruciate and the collaterals, and correctability of the deformity, examining his new vascular status, spine, and the hips. I will do investigation in the form of imaging. I will get a plain radiograph for the knee, full weight bearing view, four views, looking for the magnitude of the deformity, the bone loss, and any other pathology, proximal or distal to the joint line. So I need to get a long leg alignment. I will do a CT scan in this case because of this bony defect on the medial tibial plateau. I will do lab test in the form of full blood count and cross matching if the patient embarking on surgery. My treatment, the aim of treatment is to improve the patient quality of life and to get a pain-free stable knee with restoration of the normal mechanical alignment, joint line, normal patellar tracking, and balanced gap. And the guidelines about that is nice guidelines. The principles, this is a complex primary knee replacement. So I need to explore options with the patients, the option non-operative treatment, assuming that had been exhausted and the patient is symptomatic enough and fit enough to surgery, I will offer him a knee replacement. And satisfaction, as the outcome of this intervention, satisfaction up to 90% and survival of the implant up to 15 years. And the specific challenges for this case is a pre-operative, intraoperative, and post-operative. Pre-operative, I need a multidisciplinary approach, an aesthetic review of the patient to be optimized prior to surgery. I need to discuss with a senior knee surgeon to get it right first time. With pre-operative planning, we're preparing different grades of constraint implant. I will use a reconstruction option for the topial pony defect, preparing augments, bone graft, screws, and cement, which is my go-to option. As in the general rule, any degree of constraining or augmentation for bone substitution, I need to use a femoral and tibial stem on either side. And based on the patient medical comorbidities, I will involve other specialties. Intraoperative, as regard exposure, I will do routine medial parapatellar, do medial exposure. On the femoral side, I will do my distal femoral cut based on the 5 degree. I will avoid overcorrection, and I will use the right side line for my rotation of the femoral component. On the tibial side, I will address the bony defect using bone cement and screws or augment according to the pre-operative planning. As regards the medial side soft tissue release, I will do after I do my bony cut, I will assess tightness, inflection, and extension, and will start by taking osteophytes, releasing the medial, posterior medial, deep medial collateral ligament, posterior medial capsule. Very unlikely we do picrusting of the medial collateral ligament, superficial medial collateral ligament. Post-operative, I will do my routine rehabilitation, wound care routine, post-operative DVT prophylaxis.